Hello and welcome to the conference session called What Are My Options with High-Risk MDS and AML? Thank you for joining us. My name is Julie Powers, and I am the Senior Director of Patient Advocacy at the Aplastic Anemia and MDS International Foundation. I will be moderating today's presentation. As we get started, we want to take a moment to recognize the generosity of our patients, families, caregivers, healthcare professionals, communities, and our corporate sponsors, including Bristol Myers Squibb, Alexion, Novartis, Apellis, Taiho Oncology, Acceleron, Genentech, Takeda, and the Every Life Foundation. Immediately following the presentation, we will do a live question and answer session. Please feel free to submit your questions at any time during the presentation. To submit a question, use the question and answer box at the bottom of your screen. Type your question into the box and press enter. Please don't include private health information about the patient in question, whether it's yourself or a loved one. Our presenter will not answer specific questions related to your diagnosis or treatment. We will try to answer all questions during the webinar, but sometimes we can't get to everyone. If we don't get to your question, please send it to us via email at help@aamds.org by calling our office during the week at 800-747-2820 extension 2, or you can send us a message on Facebook, Twitter, or Instagram. If you have questions about COVID-19, AAMDSIF has an entire page dedicated to that. If you go to our website at aamds.org, at the very top of the page, there's an entire link about COVID-19 at the very top. Today's specialist is Dr. Nathan Punwani, a clinical professor, assistant professor and bone marrow transplant physician at Cedars-Sinai in Los Angeles. Dr. Punwani specializes in treating patients with leukemia, lymphoma, and blood disorders. Dr. Punwani graduated from the Drexel School of Medicine and also earned his Master's of Public Health from Harvard University School of Public Health. Please join me in welcoming Dr. Punwani.
Hi, everybody. Good morning if you're on the West Coast, or I should say good afternoon if you're on the East Coast. Thank you for having me come speak at the AAMDSIF. So happy Saturday, and we can start this presentation. What actually got me interested in MDS and AML is that the bone marrow, and that kind of the blood that it produces, I think is a very good black box for understanding how aging works and how inflammation works and how those two forces come at play to create problems that we need to cure. And for the longest time we didn't have many treatments, but now the pipeline's increased to the point now we've had 6 new drugs approved since 2016. So it's a very exciting time. I'm glad to be speaking with everybody. Let's see, next. How do we go to the next slide? Okay. Perfect. So what is in blood and where does it come from? So in normal human blood, really in most animal blood, really, you have blood vessels that transmit blood, that blood flows through. But inside blood, you have 3 major types of cells. One of them are platelets. These are cells that actually prevent bleeding. They reduce your risk of bleeding. You also have red blood cells, and that's what carries oxygen. And it also carries carbon dioxide, which you can breathe out, and it retains the oxygen you breathe in, and it transmits that oxygen to the rest of the body. And then the other type of cell is white blood cells, and those help fight off infections. They prevent infections. And where do all these cells come from? And they actually all come from baby cells. Those baby cells are stem and progenitor cells. And where do those stem and progenitor cells live? They live inside the bone marrow. And the bone marrow is actually a very, very intimate network. It's not just stem cells, but it's bone, it's fat, it's nerves, it's blood vessels. So it's a big three-dimensional model that you can see here. And it's a big network of different types of tissue systems all living together that serve as a nursery for stem and progenitor cells. Next slide. Okay, perfect. And you can see here that there's like a hierarchy to stem cells, and these stem cells have the ability to replenish themselves, but then they also, some percentage of them are allowed to kind of go to the next phase of evolution and mature. And then after that, a subset of those cells will mature a little bit more until finally they'll lead to the normal white blood cells, red blood cells, and platelets that we need to survive. So we're born with a pool of stem cells, and these last as long as we're alive. But it's a very dormant population of cells. They don't do much. They kind of sleep most of the day. They sleep most of their life. And really on a given day, only 1% of them are actually maturing into more short-term stem cells. And of those short-term stem cells, only 5% of those are actually becoming progenitor cells. And it's those progenitor cells that actually sustain our day-to-day blood production needs. That's what we call these MPPs, multipotent progenitors. Those are really the ones that drive most of the differentiation. And whenever you need that platelet or you need new red blood cells, it's these guys that are actually providing most of those needs. But the underlying source of those cells, the stem cells, they're really not doing much. They're sleeping most of your life, really. So, but you could see, we don't really, most of our cells, most of your blood cells are really coming from an underlying population of cells that are actually very quiescent. Next slide. But now you can see here's this stem cell family tree, and you can see you have all these stem cells maturing into progenitor cells, and then these progenitor cells become normal red blood cells, white blood cells, or other types of white blood cells, or maybe they go on to become platelets, or they go on to become red blood cells, right? But you can see with each of these divergences, you have a node where anything could go wrong. And you could see how intricate this process is. Any disturbance anywhere in this step of differentiation and evolution and maturity of these stem cells into normal, healthy blood and immune cells along this process map, you could end up having a very disturbed bone marrow. And as a result, you have shortages in red blood cells and white blood cells or platelets. And sometimes those shortages are accompanied by having cells that are just abnormal looking, just under a bone. When you look at them under a microscope, they just look abnormal and they don't look very mature, or they look very dysfunctional. So I know this is a complicated slide, but the idea here is you can see there's at least, many different branching points, and just any step in the way that goes wrong, you could end up developing a very abnormal bone marrow with abnormal blood production and shortages of different blood types. And I think that's the key thing to take out from this slide. And really just anything could go wrong. And that's what myelodysplasia really is. As I like to joke with my residents and my fellows, that myelodysplasia, all myelo means is blood. It's Greek for blood, and dysplasia just means abnormal. So it doesn't require much intelligence to be a doctor. You just have to come up with a fancy Greek term, combine them together, and you sound smarter than you really are. But it's a very all-encompassing, very elastic term to describe just about any perturbance that occurs in blood. You can call it myelodysplasia. Next slide. So why do you get disturbances? Why do you get these divergences and the branching points where you can end up having reduced blood cell counts, whether it's white blood cells, platelets, or red blood cells, or maybe all of the above. And it's usually some kind of genetic mutation. And I know this is a big litany on this chart over here, but you just can see that you might sometimes have a genetic mutation that, for example, impairs differentiation. It prevents the stem cells from fully maturing. Maybe you have something that leads to one of the stem cells growing out of control, so you have abnormal proliferation. Maybe you have a mutation that prevents the genes from being transcribed appropriately, so the cells have bad instructions on how to grow and what to grow. And any of these mutations, you end up having errors in replication, and then you end up getting kind of shortages in red blood cells, white blood cells, and platelets. And then on top of that, they can look very abnormal looking under a microscope and very dysfunctional. For example, the white blood cells might be there, but they don't produce anything to kill bacteria. So even though you have them, they just don't do anything. They're very lazy and very low energy. So that's kind of how you should think of this problem. We always want to know, is there maybe a genetic mutation? And it doesn't necessarily have to be a mutation you're born with. It just happens over time with just normal existence. We all have cells, and those cells have turnover, and they have to reproduce themselves. They have to replicate themselves. But unfortunately, when you do that long enough, over many, many decades, and then what happens is it's like a photocopy of a photocopy. And over time, just like a photocopy of a photocopy leads to a very fuzzy image. Well, similarly, when you photocopy genes over and over again for decades and decades and decades, you end up getting errors in those genes. And then just like that fuzzy photocopy, you end up getting these mutations. So they're not necessarily inherited. They're what we call somatic. They're just acquired. Next slide. But genes are not everything. As I like to tell a lot of our students and other doctors, if you actually think about it, compared to other cancers, and myelodysplasia is really a cancer. It's a cancer of stem cells in the bone marrow. And over time, that can lead to a really bad leukemia, which we call acute myeloid leukemia, or AML. If you actually look at these kind of bone marrow cancers, especially like these myeloid bone marrow cancers, they actually have the lowest mutational burden out of all the cancers, one of the lowest. So what that means is oftentimes when you run and sequence the bone marrow, you don't get many genetic mutations picked up, especially compared to more solid organ cancers, compared to like colon cancer or skin cancers, or lung cancer. Those cancers have a lot more genetic mutations that lead to the growth of those aforementioned cancers. But the myeloid cancers probably have only a quarter, maybe up to half of the mutations that are seen in other types of neoplastic processes. So if you really think about it, genes can't be everything. There's probably something else that's going on that leads to myelodysplasia and then later causes that myelodysplasia to evolve further into more aggressive AML, acute myeloid leukemia. There has to be something going on, and genes can't be everything. And that's why it's so helpful to think of the bone marrow. It's a very good black box view of understanding inflammation and aging. You realize what happens is it's not just the genes. Many times the very microenvironment, the environment which a stem cell that nourishes the stem cells in the bone marrow gets corrupted. Perhaps you have what we call an altered stromal response, and maybe you have a lot of inflammation going on. Maybe it's because of all the kind of pollution or red meat or what have you, but it ends up corrupting that environment, and that environment becomes very hostile and toxic, and that's what leads to stem cell death, or maybe it prevents some of those progenitor cells from maturing. And then the other thing, what happens is if you have a very inimical environment, the only stem cells that can survive are the most aggressive, most mutated, most smoldering. And that's what those stem cells that are remaining are going to be a natural nidus, a natural impulse to become a cancer, because it's survival of the fittest. If the environment is corrupted, then the only things, and it's very hostile, then the only things that can survive are stem cells that have proven themselves to be the fittest. And unfortunately, those tend to be the most cancerous, because cancer is this abnormal growth. And if you have the potential to grow in the most rugged or toxic microenvironments of the bone marrow, then naturally you're going to want to just grow out of control, especially if you're the only dominant stem cell in the pool. You can think of it analogous. It's kind of like ecosystem science. It's like chopping down that tropical rainforest. You have a nice, diverse environment full of nice, beautiful animals. But then if you end up killing the very environment that nourishes that biodiversity, you end up getting less diverse animals, and those animals might actually grow out of control, especially if it's the ones that, for example, that can only survive in a very inhospitable environment. It's very analogous to that. Next slide. And this just sort of sums up kind of different factors that can happen. Any kind of inflammation, any like diabetes, for example, any kind of autoimmune disease, any kind of infections, all that occurs over time, can accelerate aging. All that kind of inflames the bone marrow microenvironment, and that inflammation tells stem cells that, hey, you guys need to grow because we are working overtime, where some cells are getting damaged. You need to replenish and offset those losses. But then when you have a lot of stem cell growth and they're kind of working overtime, there's stress that leads to genetic damage. That genetic damage leads to mutations. And if those mutations lead to a portion of those stem cells to kind of have a more proliferative advantage over other cells, then they grow at the expense of the rest of the stem cells. That's that portion that has that mutation. And then they end up becoming very clonal, very aggressive. And that's what sets the stage for MDS. And if you don't clear up that MDS, or if we don't maybe cool down the inflammation, and over time that can lead to low blood cell counts and cell death. But then if you overcorrect and you don't, you maybe cool down the immune system too much, perhaps you end up losing the very ability to control cancers from coming up in the first place. So it's like a double-edged sword that you're dancing on when you have too much inflammation and your body's unable to kind of regain its balance, especially in that bone marrow setting. So next slide. So I like to, we know that genes aren't everything, but we know the immune system is everything. And it seems like myelodysplasia, you can really dichotomize according to the kind of the oscillation of the immune response. So lower risk forms of myelodysplasia, that's more because of you have too much immune activation all at once. So you have a lot of inflammation. And as a result, for example, you have less immune cells that regulate the immune system. So the other immune cells that become more active, and they kind of lead the attack against very corrupted, rogue bone marrow stem and progenitor cells. And they clear them up, say, hey, you guys are potentially going to lead to cancer. We got to eliminate you from the system. But then if you eliminate too many of those cells, then you don't have enough cells to support the number of red blood cells and platelets or white blood cells that you need. So it's you could think of it as low risk MDS, more blood cell counts that are reduced, and it's because there's a lot of bone marrow inflammation that leads to stem cell and progenitor cell death and decline, leading to shortages in those blood cell counts. But the flip side of that is more late stage, aggressive, high-grade disease, where what seems to happen is that you have a lot of the body is just basically taken a lot of inflammatory damage, a lot of inflammatory insult, and it just has had enough of it. And what it does is try to turn off the immune system, and you have more regulatory immune cells. You can think of them as the thermostat, and they control that thermostat of hot and cold, and then they make everything cold and say, cool down the immune system because we've led to too much bone marrow cell death. Unfortunately, you might have accumulated during this time very dysfunctional stem cells. Those stem cells are precancerous, and if you don't have a good immune system to clear them, then those corrupted stem cells will lead to leukemia. And then on top of that, what seems to happen is because the immune system is so cooled down, the immune cells also get lazy. They have less ability. They're very dysfunctional. And like I say, low energy. They can't really do much. They've just atrophied, and they don't clear up the bone marrow from these toxic stem cells that are kind of a nidus for cancerous growth, for leukemia growth. So you can think of this as this late form of the disease as less immune activation, less inflammation, less bone marrow death, but then too much proliferation of those stem cells. And usually by then, these are very toxic stem cells that are destined to become leukemia. So it's all about achieving a balance between hot and cold and achieving a Goldilocks environment in the bone marrow. And anything that goes awry, you end up having MDS. And then if you have, too little inflammation, then you have too much cell growth, and that cell growth tends to be cancerous and leukemic in nature. And if that happens over time, that'll become an AML, an acute myeloid leukemia. Next slide. Okay, good. So you can really, how do we treat this? And, you can think of the treatment, there's a lot that we can offer in that therapeutic armamentarium, but the treatment should not be worse than the disease itself. That's, our mission as doctors is do no harm. That's our Hippocratic oath. So the treatment needs to be proportional to the degree of severity. So oftentimes, like I say, for myelodysplasia, sometimes it's just a mild shortage in red blood cells and platelets. Oftentimes you can just watch it. The shortage might be so mild, they don't even need transfusions. So if patients are doing well, they have a good quality of life, they're still going to work, they're exercising, going on beautiful hikes. If they're that fit, and the degree of cytopenia, the degree of shortage in their red blood cells, white blood cells, platelets is relatively minor, then just watch them. That's actually all you have to do for these low-grade forms of the disease. If the degree of shortage is more substantial, then you just give transfusions. Sometimes we can give growth factors, kind of a hormone injection to boost blood cell counts. Then you can like I mentioned, these low-grade forms of the disease, you can maybe do an immune modulator. After all, like I mentioned, the lower grade forms of the disease is accompanied by a lot of inflammation, a lot of immune activation. So if you tell the immune system to shut up a bit, then you can offer some of these immune modulators, and maybe you get better blood cell production. So that's why we have a new drug, or I shouldn't say new drug, but we've had it really a form of it since the 50s. But we have lenalidomide, and we have other immune suppression like tacrolimus, antithymocyte globulin. So those are different options. But for higher grade forms of the disease, that's the tougher nut to crack in some ways. And that's the only curative option is a bone marrow stem cell transplant. And you can think of it as these high grade forms of the disease. The bone marrow environment is so corrupted, the stem cells have become so decayed and senescent, and they're so prone to developing leukemia that the only thing is a fundamental overhaul of the very stem cells in them. And that's where you have to get stem cells from somebody else and transfuse them into the recipient who has the MDS or the acute myeloid leukemia if it evolves further. If patients don't have a match or they don't have an appropriate match for a transplant, One palliative measure, or if they can't tolerate a transplant because it's too risky, then one option is something called hypomethylating agents. These are called HMAs. The two big names are decitabine and azacitidine. And I'll talk more about their mechanisms of action and how effective they are in a subsequent slide, but that's the palliative standard measure for MDS treatment. Okay, next slide. So to talk specifically about some of these supportive interventions in our therapeutic armamentarium, we have transfusions. Typically about 40% of low-risk MDS patients and over 60% of high-risk MDS patients will need transfusions. The more transfusions a patient needs, the worse their outcomes are and the less likely they'll survive. And then we ideally try to limit red blood cell transfusions. So what we do is we set a hemoglobin goal of 7. And if it's under 7, we try to encourage transfusions only in that more circumspect circumstance, because, too many transfusions are bad, especially red blood cell transfusions, because those red blood cells have hemoglobin and that has iron in it. And when those red blood cells die in 3 to 4 months, that iron can't escape the body and it gets deposited in our heart, in our liver, and that leads to over time organ dysfunction. So that is life-threatening over time. So too much of a good thing becomes a bad thing. Also, I like to think of red blood cell platelet transfusions as like a coal or oil. These are finite natural resources. And over time, when you do too much of it, those resources get exhausted. If you consume too much, they get exhausted. And what happens is your body exhausts themselves because it produces antibodies to all those transfusions. So eventually, then you just stop responding to transfusions because your body really eliminates and as a result, you just don't retain any further transfusions. So these are kind of resources for the future that should be maintained and given only when we really need it and in very gentle moderation. If too much iron overload occurs with all these red blood cell transfusions, we can offer iron chelators to kind of remove excess iron. And there's some data to show in a retrospective cohort of patients who received it, they were more likely to live longer than those who weren't given iron chelators. Because you were able to, the theory is you end up removing excess iron, so you don't have so much circulating around in different organs, leading over time to end organ dysfunction. So next slide. So like I mentioned about hormones. Sometimes you can give hormones to boost up white blood cells, red blood cells, and even platelets. We have epoetin and darbepoetin. These are erythroid stimulating agents, or ESAs. These are boosting, you can think of these as red blood cell boosters. These are hormones that boost up your red blood cells. And about 30% of patients will have a response after about 4 months of treatment. So that's what we usually do. And you can do it like on a Monday, Wednesday, Friday basis, or you can just do an injection once a week. What we could also offer is a white blood cell booster, something called GCSF. The big brand name is like Neupogen or Neulasta. Typically, we try to avoid Neulasta because it like the name suggests, Neulasta, it lasts too long, and we don't want something to last too long as side effects could accumulate. So what we usually like to do is something more short-acting, like Neupogen or filgrastim. They can boost up white blood cells in over 2/3 of patients, but we as a practice try to eschew regular use of GCSF because patients who have higher risk forms of MDS, they tend to have less survival. We don't quite know why. It doesn't seem to lead to higher evolution of that MDS into AML, but we do know for whatever reason, overall survival is shorter. So as a result, we tend to only try to use it when we really have to, maybe if there's a severe infection that's going on, and try to concentrate the use of these agents in low-risk MDS. So maybe it's a low-risk MDS who doesn't have much leukemia, but they have low white blood cells, then we give it in those situations. if an MDS patient has too low platelets, we can give them the TPO receptors or receptor agonists. These are TPO agonists. So the big ones are like N-plate, romiplostim, or the other one is eltrombopag or Promacta. But you could give that to MDS patients, and as a result, they respond. They don't need as much platelet transfusions. Unfortunately, this is not FDA approved, so it's off label, but it's something that is in regular practice. But the concern with this is, and there's documented evidence that there's a higher risk of turning that MDS into acute myeloid leukemia. It's almost a 3-fold increase in relative risk. So for those reasons, we may not want to give it for people with high-risk MDS, because we don't want that high-risk MDS to become a leukemia. Next slide. I'm just gonna, just for the sake of time, not focus too much on this, because this is kind of more of a medicine as an art rather than a science. But sometimes you can give immune modulators to cool down the immune system. Sometimes if all these treatments fail and patients still have low risk MDS, sometimes you can give short courses of immune suppression like tacrolimus. But the evidence base behind that is in a much more gray area. Something that is less of a gray area, and there's a lot of science and evidence base to back it, is lenalidomide, given for a specific type of MDS. So it's a particular type of MDS where there's an aberration of the 5th chromosome we have. And in that very select group, you get very exquisite responses to lenalidomide, which is an immune modulator. The trade name is Revlimid. And as a result, these are patients who get over a 2/3 response. They become transfusion independent. They have such a beautiful response, and it lasts for more than 2 years. And on average, people's hemoglobins go up by 5. So for example, if these patients are having a hemoglobin less than 7 and they're needing chronic transfusions, they go up to 12 thanks to this drug. So it's in some ways it's a miracle for the subset of patients who have this particular chromosome derangement. There has been studies evaluating lenalidomide in other MDS patients, but the outcomes are rather fleeting and are relatively dismal. Only a quarter of these patients will actually become red blood cell transfusion independent if you just give them to everybody. And they don't last more than 10 months. So like I said, it's not like these are the other forms of MDS patients where they're never needing transfusions and you can watch them out for 2, 3, 4 years and they're doing fine, living a normal life. These are patients who probably at the end of a year, the effects just sort of burn out and they're just, they're starting to need transfusions again. So I don't routinely use it in my practice. I think what's better for these patients is to do a clinical trial. Next slide. So this is the other option, like I was mentioning, something called hypomethylating agents. This is a very good treatment we offer, but we offer it mainly for high-risk myelodysplasia. And the idea behind this is these are agents that kind of activate your own endogenous tumor suppressor genes. What it does is it awakens the genes that we have in our body to fight cancer and to kind of suppress cancer growth. They kind of put the brakes on cell growth. And by putting the brakes on that cell growth, you end up preventing leukemia from forming. So that's what we call it, azacitidine, decitabine. Those are treatments that you can offer. These treatments also have other mechanisms than were traditionally understood, but now new science has come out that these drugs also evoke a very potent inflammatory response. Like I said, in higher stages of MDS, there's less inflammation and more cancer growth because you don't have as much immune surveillance. So these agents kind of wake up the immune system And what they also do is encourage the most healthy stem cells in the bone marrow to divide and to produce more mature functional blood and immune cells. So it kind of alters the contribution of these stem cells, encourages the healthier ones to offset any production or from the more corrupted pre-leukemic stem cells. So tries to alter the balance of the two in favor of the stem cell pool that's more healthy. It gives them a kind of a fighting edge or a more competitive spirit relative to the more toxic, corrupted pre-leukemic stem cells. And these agents are fairly effective. Almost 20% of patients will achieve a complete remission where they have no leukemia on their bone marrow. And even if there's still some leukemia, it reduces it. And then almost 20% of these patients can achieve a hematologic response, so their blood cell counts go up, whether it's the red blood cells, platelets. The side effects of the drug, it's very well tolerated. We give it to people even in their 80s. But the thing is paradoxically, it can cause some cell counts to decline. It's not very predictable. Over time, those cell count declines moderate and improve because, like I said, you encourage the healthier stem cells to divide more. But it takes a while. Stem cells, like I say, they're only on average 1% per day differentiating. So it's a very quiescent ecosystem. So because something's only differentiating 1% a day, don't expect a fast response. You need at least 4 to 6 months of the treatment to really know if you're failing or not on this particular type of hypomethylating agent. But typically, though, the responses last for about a year or so, and then over time it fizzles out, and then the leukemia, then the MDS progresses or becomes full-blown leukemia. Next slide. So in terms of the only known curative option for MDS is bone marrow transplant, where you find stem cells from a donor. It could be a matched sibling donor, like a full match, or it can be an unrelated donor who's a full match or close to full match. Increasingly, we can even now do a haploidentical transplant, and you can think of that as a half match. So now these are half match transplants that are related to the recipient. So it could be, a brother, a sister, or even a son or daughter. So now as a result, now almost everyone now has a donor, as long as you have maybe a son or a daughter. Even sometimes your cousin can be, there's a 25% chance that they're a half match to you. So as I like to say, you never know when you need somebody else's stem cells. So be nice to people on Thanksgiving, or Christmas during the holidays. But so as a result, now almost on average, most people have 2.5 donors. If they need a stem cell transplant. But stem cell transplant, it's a tough process. You still need some chemo and radiation as part of the preparatory regimen so your body can accept another person's stem cells. You don't need much chemo and radiation. So as a result, even older folks can get a bone marrow transplant. But unfortunately, MDS is a disease that's predominantly in the elderly. And as a result, not everyone's going to get a transplant because they may have, say, a lot of chronic medical conditions. In addition to their MDS, they may have a history of stroke, heart failure, coronary artery disease, diabetes. All that increases your risk of getting intolerable complications with a post-transplant. So even though we have much more ubiquitous donor pool than before, and we are now learning to use less radiation and chemo, and even we're transplanting people in their early 70s. These people need to be very fit elderly. So even with bone marrow transplant, we still have 50% relapse rates even after transplant. So it's not a guaranteed success, and there's high risks of side effects, mainly infection and something called graft versus host disease, where that transplanted immune system actually attacks the recipient's body, which is GVHD. So it's all about, as they say in the Odyssey, navigating between Scylla and Charybdis, between the sea monster and the whirlpool. And that's what transplant is. It's about, if only for that select group of patients who you can navigate through two big risks, the risk of the MDS AML or the risks of the transplant killing the patient. So it's kind of high risk, high reward. Next slide. If that MDS eventually becomes AML, for fit elderly patients, we can give them chemotherapy. It doesn't, or even really just any fit patient, you just give them. I don't even like to have I'm not an ageist. I think age is just a number at the end of the day. As long as they're healthy, you probably can get away with chemotherapy. Typically for people who are under the age of 60, you get a 75% complete remission rate. With chemo, the chemo is something called nicknamed 7+3. It's 7 days of one chemo and 3 days of another chemo called anthracycline chemotherapy, and then you combine it with cytarabine. So that would be something you could offer, a doctor could offer. But unfortunately, like I said, the average incidence of AML typically is around the age of 63. That's the average age of diagnosis. So patients older than the age of 60, the response rates to chemo, it tends to be worse, especially if they had a history of MDS beforehand, what we call secondary AML. It's secondary to their underlying MDS. You typically get only 20 to 40% remission rates in those circumstances. So the patient really better be fit if you're taking a gamble with something that can be very toxic and cause a high risk of infections and kind of mucositis, a lot of oral ulcers, mouth pain, gut pain, a lot of risks with this chemo. If we get them into remission, then you consolidate that remission. And if it's high risk, you can give a bone marrow transplant, or you can do this cytarabine chemo that they received in this induction phase of the treatment. You give them that, but maybe at a higher dose for about 2 to 4 months, depending on how patients tolerate it. If it comes from AML, or if the AML comes from MDS, it typically is high risk, and we would, if patients that were relatively fit, we would try to encourage them to be a bone marrow stem cell or undergo a bone marrow stem cell transplant, but typically on balance, but everyone's different. Next slide. 7+3 can be repackaged in fat molecules, and that new drug is called Vyxeos. It just got approved about 5 years ago, or no, actually not 5 years ago, around 2018 or so. So it is basically the same 7+3, but packaged up into fat molecules. And that's something you can give to fit elderly patients, especially if they have a history of secondary AML, especially in that cohort. And that actually increases the remission rates almost to 50%. So like I was saying, typically with the traditional 7+3, it's only a 20 to 40% remission rate. This, thanks to Vyxeos, can go up to 50%. And you end up reducing early mortality rates by almost half with Vyxeos compared to traditional 7+3 chemo. And it's also correlated with improved survival up to 10 months on average. Next slide. But really, it's very, like I say, AML and MDS is a diagnosis of predominantly of elderly patients. And if they have a lot of comorbidities, there's no obvious standard of care in that situation if they're not a chemo candidate. Oftentimes AML in the elderly population, because there's some element of MDS that resulted in their leukemia, there's a lot of genetic chromosome errors, so they tend to be very chemo insensitive, and the remission rates are very abysmal. I mean, we're talking about 10 and 20%. So we try to encourage a clinical trial in this circumstance because there's no obvious standard of care, but there soon is starting, at least we're starting to have an emerging consensus. Next slide. is called venetoclax, and you can combine it with those hypomethylating agents that I mentioned earlier. And that seems to be kind of an emerging consensus brewing that could be the standard of care for fit or for elderly patients who are ineligible for chemo, really just any patient who's ineligible for chemo. And that, we're getting almost a 3/4 complete remission rates, and average survival goes up to 15 months. Like I mentioned, with HMA alone, we're starting to see around the 9th, 10th, 11th, 12th month, kind of the therapeutic benefits getting exhausted. But thanks to venetoclax, in addition to HMA, when you partner them together for AML patients, we're getting longer, more persistent responses. So we get more people into remission, and the remissions last longer. It's very well tolerated. I mean, I give it to people who are in their early 80s, and they're able to tolerate it. But the side effects are, you can have low white blood cell counts. There's a 40% risk of infection, diarrhea. So I recommend that patients get, at least in the first couple of months, at least their complete blood cell count checked once a week by their doctor if they're on this drug, and they need to be transfused accordingly and need to be on good preventative antibiotics. I think that's pretty much it for time. And I think that's actually how I wanted to conclude. Should we just open it up for questions?
Thank you so much, Dr. Punwani. We do have a lot of questions, so I am going to I'll read them out loud to you, and then if you want to take the questions, I will hand it over to you. First question comes from a patient who is inquiring as to how does monosomy 7 factor in with MDS?
Oh, very good question. So monosomy 7, for everybody to understand, they're basically, you have 2 chromosomes, right? One from mom, one from dad. In monosomy 7, you only have one of the chromosome 7. So it's like you're missing the other partner chromosome. And what happens in that situation is those patients really, we tend to want to give them more decitabine or azacitidine, because it's that subset of MDS patients that are more responsive to those hypomethylating treatments, are more likely to have higher complete remission rates, and they tend to be more high-risk MDS. So that's something that I would consider for patients with monosomy 7, is that they're probably more likely to benefit from azacitidine or decitabine, and especially if they have low blood cell counts, or if they're leukemia, their blast percentage is high. They're the ones who are more likely to benefit from it. It's typically high risk, and generally you'd want to encourage bone marrow transplantation.
Thank you, Dr. Punwani. Our next question comes from someone who wants to know, what is on the horizon in terms of post-transplant patients who may relapse? Are there any thoughts there for the higher risk MDS to AML patients after transplant?
Yeah, so there's actually a lot of good studies that are in this space. The idea of maintenance is that maybe bone marrow transplant alone is insufficient to induce a long-standing remission. Maybe you need something else. So there's a lot of science going into like immunotherapies. So some of the drugs that actually I was working on was atezolizumab, and that drug, the idea is that maybe you can have a more potent graft versus leukemia effect, a more formidable one. So you have a transplant, what we call the graft, and that immune system from that graft, the donor's immune system, you can make it more powerful to police and give better immune surveillance against any corrupted stem cells or pre-leukemic stem cells. Because like I said, the stem cells don't divide a whole lot, so chemo doesn't work. So that's for that reason you have to give maybe an extra punch to that immune system. So I think the big thing on the horizon is the immunotherapies, like checkpoint inhibitors.
Thank you so much, Dr. Punwani. Our next question comes from a patient who has lower risk MDS, but requires blood transfusions every 4 weeks. Their hemoglobin tends to drop below 8. Is it beneficial for them to once in a while take decitabine or azacitidine to clear out the blasts and kill off cancerous bone marrow stem cells while continuing to maintain their transfusion regimen?
It depends on how it's sequenced. If if they're low risk MDS, so I'm assuming that. So if their blast percentage is maybe less than 10%, that's kind of the cutoff. It's reasonable to consider more of the erythroid stimulating agents. And then if, for example, patients fail on that after they've had at least 4 months of it, then it's more reasonable to consider decitabine at that point. I usually don't try to sequence it and do it up front because, of course, decitabine sometimes can bring down blood cell counts, at least initially. So for that reason, I try to reserve it later, especially if it's a earlier form of the disease or a low grade form of the disease. Try to focus more on transfusions and growth factor support.
Thank you, doctor. Our next question comes from a patient who wants to know if Aranesp alone and luspatercept have failed to produce transfusion independence and the hemoglobin range continues to be in the mid-7s to low 6s with transfusion every 4 weeks. Why would lenalidomide and Aranesp be considered as a viable option for low to moderate risk MDS?
With lenalidomide and what else?
Lenalidomide and Aranesp.
Oh, but I think the question earlier was they were saying that they also got some kind of, they got transfusions and what else?
Aranesp and luspatercept.
But before that, they were getting just only transfusions, or?
They're getting transfused. They're getting This question is a little complicated, and I'm not sure I'm doing it justice, and my apologies. But it says if Aranesp alone and luspatercept have failed to produce transfusion independence, and the range stays in the 7s with transfusion every 4 weeks, why then would lenalidomide and Aranesp together be considered a viable option?
Generally, like I said in the earlier slide, I don't think it's not so much it's a viable option. It's not exact, like you get a response, but it's a very fleeting response, and benefits of lenalidomide get exhausted by that 10th month on average. So I wouldn't call it a viable option. It's just a stopgap option. I think in those situations, you may want to discuss the option of bone marrow transplant if the patient is fit enough. But the other option would be actually preferably a clinical trial in those situations. But it's more of a last ditch effort, a salvage effort, rather than anything in terms of anything that we would expect something of sustainable benefit.
Thank you so much, Doctor. Our next question comes from actually with several questions about age related to treatment decisions. As you noted, many patients are diagnosed with MDS, higher risk MDS as elders, often in their late 60s and even into 80s. Mm-hmm. What's the tipping point, in your opinion, on age for which course of treatment? Should they go to transplant if they're in their mid 70s and really fit? Where, what's the tipping point? What are the biggest factors that you consider? And, is there a benefit to going to transplant earlier if you're more moderate to high risk MDS, but younger? What's the benefit?
So anyone with moderate to high risk MDS, especially if they're younger, they should be referred to transplant very early on. The outcomes are much better. So that's actually something that we would recommend, and that's something that we would strongly endorse. There's, like I say, age is just a number. I mean, I'm sure different institutions will have different cutoffs. Generally, after the age of 75, then it becomes more difficult to do a transplant because we can end up getting over 20 to 40% mortality from the transplant, and not mortality from their underlying MDS or leukemia, but actually just from the transplant itself, mainly from infection and graft versus host disease. So I think I would say informally, maybe age 75 would be our cutoff. But it needs to be also a very healthy 75, a sprightly 75. It couldn't be someone who's not out of bed majority of the day or who has multiple chronic comorbidities.
Thank you for the clarification, Doctor. Our next question comes from a patient who is treated primarily by their local hematologist who does not have expertise in high-risk MDS, and also diagnosed their disease by a CBC. Can you offer some suggestions for them for what their next steps should be in terms of treatment?
So it's a high risk MDS. It would be most curative to do a bone marrow transplant. So, if they're fit enough, they should be actually referred to an academic medical center or a transplant center in particular for that transplant evaluation of bone marrow transplant. That would be my preference. In the interim, their outpatient oncologist in the community can actually provide the decitabine or the azacitidine to get their leukemia, their blast percentage down below 10%. And you have better outcomes that way if you get maybe that, or at least I shouldn't say you get better outcomes that way, but there is, based on retrospective data, some evidence to suggest that if you kind of cytoreduce before transplant and kind of reduce that leukemia percentage below 10%, you get the best outcome after transplant. So it's not just about going to a transplant center, but you can also have to dovetail that with a good community support from your community oncologist.
Thank you so much, Doctor. We have a question from a patient who notes that prior to transitioning to AML from MDS, they relapsed from a bone marrow transplant, and the doctor said it was because trisomy 8 returned. Can you help us understand what trisomy 8 is in this situation?
Yeah. So trisomy 8 is just a fancy word for saying that you have an extra chromosome 8. So you have, in this case, like I said, you get 2 chromosomes. You have a pair of each chromosome. And in this case, the 8th chromosome, you have an extra copy of it. So why that happens, we really don't know for sure. But it kind of goes back to that slide that it's much like people over time, with just existence, you have your cells replicating, and with all that, you have your chromosomes and your DNA replicating with it. And when you do it enough times, and it's like that photocopy of a photocopy, and then things could go wrong. And that's why you end up maybe gaining a chromosome in that process, because that image just got very fuzzy. In a very visceral level, that's how I would explain it. The thought process is because the stem cells have that extra chromosome 8, that chromosome, or maybe that cell that has that chromosome, has a competitive advantage, a survival advantage that allows it to thrive and allows it to come back. May not necessarily be itself from the chromosome 8 itself, maybe it has some other gene that goes with it, a genetic mutation that goes with it. But the point is there is a strain of these cells that certainly it's accompanied by an extra chromosome 8 that just has a more fit advantage, and as a result, that's what allows it to come back.
Thank you for the clarification. There is a trend amongst MDS and MDS to AML patients to thoroughly understand what their mutations are. Can you help our patients understand a little bit about sort of, for example, in this case, the patient is inquiring about the TP53 mutation. Is that a good one to have? Is that a bad one? What would you say the prognosis is in this situation?
Yeah, TP53 is one of the most important genes that we have, and it's a tumor suppressor gene. And whenever you have a loss of that, it's like taking the brakes off the gas pedal and things accelerate, and you have uncontrolled cell growth. And so that's a high risk mutation. And unfortunately, when you take the brakes off and you have so much cell growth, when you don't have an orderly transition of chromosomes, and as a result, you have missing chromosomes in some cells, and you have gains of chromosomes in other cells, and you have these very complex chromosome patterns, and then that becomes extremely high risk. And unfortunately, that is such a disappointing diagnosis to have, because unfortunately, even with bone marrow transplant, there's a less than 10% survival. So at that point, I think what I would recommend is a clinical trial and going to a center of excellence that has one, ideally one that's specifically for TP53 mutated patients. If it's TP53 mutation alone, and at least you don't have those aberrant chromosome patterns, then it's reasonable to transplant those patients. But we at Cedars, we avoid transplanting TP53 with complex chromosome features because of outcomes are bad even after transplant.
Thank you, doctor. We have a question from a patient who has a child who was a pediatric AML patient, but who has since grown and is thriving, went to transplant as a child, and is now thriving and is actually in their second year at a school near you. This parent is inquiring as to what things in your assessment that as an adult patient, should this former pediatric patient be looking at in terms of long-term health? Are there bone health concerns? Are there things that they should be aware of in their 20 as a 20-something?
Is there any way to find out like how long ago the transplant was?
According to the parent, the transplant happened when they were 8, so 12 years ago.
Okay.
Sorry, 14 years.
Yeah, so the main thing to always assess for is something called graft versus host disease. And it's when, the idea behind transplant, it's the ultimate immunotherapy. You're transplanting somebody else's stem cells, and those stem cells become a new immune system. And that immune system ensures that you have better surveillance against leukemia. Unfortunately, like I said, that many times that immune system views the body as very foreign and then it attacks it. So that's graft versus host disease, GVHD. And what I would do is monitor for chronic GVHD, especially 10 years out. So oftentimes those are kind of what we would attribute kind of like autoimmune-like symptoms, but it's not really an autoimmune process, or at least not exclusively. But things to watch out for is like a pulmonary fibrosis. So make sure they have at least recently some lung function studies, or at least at some point they should have had it, because they could be scar tissue around the lungs. They can develop more kind of like if you go hiking and you see kind of lichen or kind of that fungus on trees, kind of lichenoid plaques on the skin. Sometimes it can get, so those are like things that I would watch out for. Many times it can also get a lot of sclerodermis kind of joint restrictions. So monitor for any joint restriction, any inability to kind of move different muscle groups or joints around. I think those are, and then of course the other big thing is long-term risks or infections. So make sure that he gets vaccinated, especially if he has no active GVHD, or at least not any undue GVHD. So we usually try to revaccinate patients after a year.
Great, thank you so much, Doctor. That actually leads nicely into our next question, because we are in the era of COVID, and COVID is on all of our minds these days. Do you have any suggestions for higher risk MDS or AML patients with active disease who are not post-transplant? Do you have any recommendations regarding COVID vaccination?
So my personal philosophy is vaccines only work if you give them. So generally I vaccinate all my like high-grade MDS patients, even if they're getting treatment with decitabine. The only patient where I'm much more circumspect about typically are the ones that they're getting active chemotherapy, because you're depleting kind of the immune cells that they may not even have a response. I still think it's also reasonable to vaccinate those. You might just expect not a more blunted immune response. They may not fully develop the antibodies, but like I say, vaccines only work if you give them. The one patient population we really don't want to give the vaccine to is mainly the ones who are undergoing bone marrow transplant or have received one, and they're on active immune suppression, because then they really wouldn't benefit from the vaccine. They just wouldn't be able to generate the appropriate immune response, the antibodies to the vaccine. So at that point, it would be fairly futile to kind of give that vaccine in that particular population. So I think it's really a spectrum of conditions, but if there's one subset of patients who probably shouldn't get the vaccine, it's really just the transplanted patients who are on immune suppression, whether it's there are calcineurin inhibitors or whether they're on high dose steroids if they have any GVHD. That's a situation where we wouldn't transplant, or we wouldn't give the vaccine.
Thank you so much, Doctor. Our next question is to confirm, it is just a confirmation question. In order to determine which mutations a patient has, what is the test done in order to determine the mutations, which mutated genes, what are the chromosomes? What is that called, and so that if people who are watching this can make sure to secure the correct testing through their treating hematologist or oncologist?
Yeah, so actually there's a few tests I would love patients to be aware about, so they can be empowered to really kind of ask their provider to get these tests done, at least especially as a first diagnosis. But like I said, AML is AML and MDS is a very heterogeneous entity. We shouldn't view cancer as a monolithic entity. It's actually many different tumors, many different subclones, each driven by a different mutation. So it's very important that we're doing adequate mutation profiling, not just at diagnosis, but at relapse. So the big things that we like to do is cytogenetics. Basically take that bone marrow and then look at actively dividing cells and then looking at what chromosome features they have. But then that's not the most sensitive test. So along with cytogenetics, we can get something called like a fish panel, which are probes that we that bind to different genes. And that's something that you can actually get tested because if there is maybe they can pick up those probes, any abnormal genes or any mutations. And then we have something even more sensitive. And what we do in that situation is called a myeloid next generation sequencing panel, where it really does sequence out all the genes. The problem is the turnaround time comes back relatively late. It takes many times 2 to 3 weeks to get a result back. So we usually, our practice here is we get those 3 tests.
Great, thank you so much. Our next question is about GVHD for patients who have gone to transplant. Can you talk a little bit about the different kinds, chronic versus acute, a little bit, and then specifically this patient wants to know about lung GVHD. Thank you.
So really, we always like to dichotomize things in medicine. We just like to say acute versus chronic, and traditionally that meant acute GVHD is any GVHD that occurred less than 100 days, or like 100 days or less after transplant, and then anything over 100 days from transplant we just called chronic. But we know that Mother Nature doesn't really follow strict rules. It's not like it's day 101 and suddenly nature's going to behave differently. So it's largely just for categorization purposes. We picked a relatively arbitrary benchmark of day 100. But the general idea is that in the first 3 months after transplant, or close, or maybe 3 to 4 months, what happens is the immune system from the transplant in those first 3 to 4 months develops kind of T cells, and those cells are very cytotoxic cells, and they aim against other parts of the body where there's a lot of cell turnover. So it attacks more the skin, it attacks more the gut or the liver. So they get maybe jaundice or abdominal pain, diarrhea, skin rashes, especially kind of eczematous or a lot of skin sloughing, those kind of rashes. So that's something how I think of acute GVHD is it's kind of this cytotoxic T cell response from the graft, from the transplant, specifically targeting those 3 major cell types: liver, skin, and gut. Then on the flip side, as the immune system sort of matures, and then we're kind of going out to maybe 4, 5, 6 months to over a year, then it's more of a chronic, we call it chronic, but really it's just the pathophysiology is different. And you might have a lot more immune cells, not just a particular type of T cell that's at play. You might have very activated B cells that are producing antibodies. And they're just sort of, it's a more multifactorial cause, but it just leads to a lot of inflammation, but that inflammation leads to more scar tissue buildup. And where that scar tissue can occur is, for example, the skin, the joints, muscle groups. Sometimes it's in the eyes, you get a lot of kind of itchy, dry, watery, scratchy eyes. And then you get that same scar tissue in the lungs. So it sounds like this patient had a transplant some time ago, at least maybe over 6 months to a year ago. and they're suffering from chronic GVHD, and it's mainly because of this pulmonary fibrosis, or maybe they have some kind of obstructive lung disease from this scar tissue buildup. Generally, the treatments we give are kind of the same treatments we give to asthmatic patients or COPD patients, which is kind of inhalers, steroid inhalers, bronchodilators, and then you can give azithromycin or Singulair, the kind of the allergy medicine, and that together helps with GVHD of the lungs. But it's not curative, but it's mainly to control symptoms and maybe prevent any further progression. But the problem is it's scar tissue. It's kind of like if you got a really bad cut and you build up a scar, it just doesn't go away. And that's the problem with chronic GVHD, is that it's very indelible.
Thank you so much, doctor. We have a question from a patient who is not going to be able to proceed to transplant due to other health concerns. They have high-risk MDS and the disease is progressing quite quickly. Their treating hematologist oncologist says that they've got about a year. And what can the patient anticipate in terms of health effects as the year progresses and as their disease becomes more aggressive?
So really the disease course manifests largely with a lot more transfusion needs. So that's something to expect in the coming months ahead, unfortunately, is a lot more transfusions. The other thing is a higher risk for infections during this time, because if it's progressing, you don't have as much of an immune system because the stem cells aren't producing enough white blood cells, or they're being crowded out by that underlying leukemia as it evolves. So I think those are like the big complications to monitor. And of course, when you have that unchecked growth, and it taxes the body. So, it's very normal to kind of have kind of some weakness, fatigue, just a muscle breakdown too, kind of just losing muscle mass. So those are some of the big factors to watch out for. If transplant's not an option, then if it becomes AML, if it becomes like a full-blown leukemia, then we could consider the hypomethylating agent with venetoclax, or you could do a small dose of chemo with the venetoclax called cytarabine. So those would be options. Ideally, also clinical trial could be an option. And if it becomes AML and the patient's fit enough, even chemotherapy could be an option, like the 7+3 or the Vyxeos. So those would all be things in the therapeutic armamentarium in this specific circumstance.
Thank you so much, doctor. Our last question is about AML pipeline. As we move forward, we've seen a lot of increase in the number of AML and MDS treatment drugs. Is there anything in the AML pipeline that you find really promising, and where would be the best place for patients to find information about clinical trials for which they may be eligible?
So the best thing is talk to your oncologist, and they can refer you to a center of excellence that's having clinical trials. Sometimes even now, a lot of community oncologists have hybrid practices where they're attached to like an academic center or have some affiliation, so they can actually run clinical trials now as an outpatient. Some of the things to watch out for, I think, so already in AML, MDS, or not so much MDS, but in AML, we have almost 7 drugs approved in the last 4 or 5 years. So we've already had a lot come through the pipeline all at once. I think the most promising thing is something called magrolimab. It's a macrophage checkpoint inhibitor. It's the macrophages are kind of these, like if you remember from the 80s Pac-Man, they gobble up cells, and they mainly gobble up bacteria and different germs. So these same gobblers can also gobble up different, like stems or like leukemia cells. So that's the new thing. I think that could be very promising, especially frontline and MDS. So that's the thing I'm most excited about. And there you get a very high complete remission rates. So that, in addition to the hypomethylators. So I think that could be an option to watch out for FDA approval in the next year or two.
Thank you so much, Dr. Punwani, and thank you for an incredible presentation today and answering so many of our patient questions. As we conclude, I want to remind everyone that at 4 p.m. Eastern, 1 p.m. Pacific, we will be hosting support groups that are virtual using Zoom. The link is on your screen, but you can also find it in the attendee hub. It's the last link on the page under the sessions. I also want to remind everyone that if you haven't done so already, we are accepting registrations for the March for Marrow, which is the California Virtual Walk and 5K. We do hope that you'll be able to join us. If we were not able to get to your question, or you have more questions now that the session is concluded, please send it to help, HELP, at aamds.org, and we will be happy to get an answer for you. I also want to note that this session will be available on demand recording on this platform, and then we will also put it on our YouTube channel in the coming weeks. Please keep an eye out for an email letting you know that this session is available. Thanks again to Dr. Punwani. Thank you to all of our sponsors, and thank you to all of you for being with us today. We hope we'll see you in our next session. As a reminder, the next session begins in 15 minutes. We are doing a special session on transplants, and then we have a pre-recorded session on chemo brain, which may be of interest to some of you. Thank you ever so much, and have a great day.